Uh, First of all, I'm grateful to all of you for taking out time and being here on a Sunday. Extremely thankful to our moderators, and I'm going to discuss regarding how we approach to urinary tract infections. It's a very simple presentation. Probably a few of you might have heard it prior, but since I think each step is important, I'm going to discuss this. So like any other infectious diseases, UTI as well presents with a very varied presentation. And as my previous speaker, Dr. Ashok Taneja sir, has mentioned that urinary tract infections can be uncomplicated as well as complicated. And when there is a structurally and a neurologically normal tract, that is uncomplicated, while complicated UTI is when there is presence of a foreign body, when there is obstruction, in men, in patients with neurological diseases, in immunocompromised patients, patients who have undergone renal transplantation, or if it's very severe UTI with renal failure, and in case of pregnancy, then it is a complicated UTI. So let's just have a quick review of the historical definitions of the UTI. Is it, the cursor is not available? Okay. So, urinary tract infection is defined as when there is a significant colony count historically of 10 to the power of 5 colony forming units from a midstream clean cat sample. Now, if the patient is symptomatic, then the definitions have evolved, and we consider even 10 to the power of 3 colony forming units per ml as diagnostic for acute cystitis. And for pyelonephritis, it is 10 to the power of 4 colony forming units per ml for the pyelonephritis. Now, we must also remember that these are classic definitions, but if the patient has received antibiotics, then there can be not a significant colony count, and then we have to clinically correlate whether it is a UTI or not. For a catheter associated UTI, the significant colony count is 10 to the power of 3 colony forming units. Okay. So, the first approach is whether it's UTI or not, and then we are going to discuss regarding the antibiotic therapy, then regarding the role of surgery or the source control. So, we have whenever there is a positive culture, like in this patient, who is a diabetic patient who is undergoing planned for surgery, has a blood culture which is negative, but a urine culture which is positive with a E. coli, and this is a ESBL with an additional mechanism of resistance, because there is resistance to the third generation cephalosporins, as we can So there is resistance to third generation cephalosporin ceftazidime, but there is also resistance to the BL-BLI combination of cephalosporin, selbactam and piperacillin tazobactam. If it was ESBL, then this BL-BLI combination would have been susceptible. So this is ESBL with an additional mechanism of resistance, and in this patient, what do we prescribe? So here these will be the options if you look at the culture report. However, we need to ask for the history, and if the patient does not have any history and look at the urine routine which does not show that there are any pus cells, then this is likely a contamination rather than a true infection. So, it has to be, any positive culture has to be clinically correlated with the urine routine as well as with the urine culture. So, we have heard this prior that asymptomatic bacteriuria is very common in elderly patients, in patients with diabetes, as well as those who are having immunosuppression. So, in those patients, in fact 50 to 60% of the times there may be a positive urine culture and no symptoms, and this is not to be treated until the patient has pregnancy, or if the patient is undergoing some urological intervention. That's when the antibiotics have to be started, and antibiotics have to be started just 12 hours prior to the procedure and can be stopped after the procedure. Now, we also must remember specifically, if suppose you have a healthy patient who is having a urine culture positive with pseudomonas, or a enterococcus in an elderly patient. These two can be a common colonizers or contamination rather than a Enterobacteriaceae, which is likely to represent a colonization or a true infection. Now let's discuss the antibiotic therapy. What should we give empirically and what should be the definitive antibiotic therapy? So the choice of antibiotics for UTI will depend upon several factors, and this includes whether the patient has got a lower UTI or the patient has a upper urinary tract or there is prostate involvement, and also it will depend upon the severity of the infection. So for lower UTI, we can go for nitrofurantoin. However, if there is pyelonephritis, then nitrofurantoin cannot be used, and nitrofurantoin again will not have good penetration into the prostate, and hence it will not be the good option. Likely organisms and likely susceptibility, which again a clinician must try to guess based on whether the patient is coming from the community or from the hospital, and the prior antibiotics which have been received by the patient even in the last few months. That will help us in identifying whether it's a ESBL or it's a additional mechanism of resistance like a carbapenem resistant Enterobacteriaceae. In a patient who is in the hospital and has undergone any procedure, any catheter has been placed, we must have a higher suspicion for a multi-drug resistant organism, especially CRA in the current scenarios. It will also depend upon the properties of the antibiotic, the various PK/PD parameters which we have to consider, whether the antibiotic is cidal or it's static. Now here the concept of cidal and static is not very clear, but at the same time we must choose the drug which is achieving adequate concentration into the site of infection. Remember that beta-lactams, fluoroquinolones as well as aminoglycosides, they have a higher concentration into the kidney parenchyma as well as into the urine. However, polymyxin B has no urinary concentration, and tigecycline, even if the urine culture report suggests that it is susceptible, has poor urinary concentration and should not be used for the treatment of UTI. We need to look at the toxicity as well as the side effects. Aminoglycosides, colistin as well as fosfomycin are associated with significant toxicity. So aminoglycosides can be used in a healthy young patient who is likely to have a lesser degree of nephrotoxicity for the treatment of UTI, but in an elderly patient, in a diabetic patient, there is a higher chance of nephrotoxicity. Similarly, colistin is associated with nephrotoxicity, and the first dose of colistin may not really deteriorate the clinical kidney function, but this may be evident after 2 or 3 doses or on the second or the third day that the creatinine function has started declining. Fosfomycin again may be associated with hypernatremia as well as hypokalemia, and it's an IV therapy. Monotherapy should never be used for fosfomycin because there is higher chances of acquiring resistance, and it should always be used with a combination therapy. Coming to allergies, we have like if a patient has got allergy to the beta-lactams, then other choices of antibiotic, say aminoglycosides can be used, or even TMP-SMX, and sometimes if there is allergy to TMP-SMX, then the other treatment options should be considered. We have to keep in mind that there has to be source control, which is extremely important, because even if because of the there is this Eagles effect, that when there is high inoculum, then the susceptible bacteria may not, we have to reduce the inoculum for the antibiotics to work. Collateral damage, when we choose, when suppose a urine culture is showing that TMP-SMX is susceptible, beta-lactams are susceptible, fluoroquinolones as well as nitrofurantoin, and it's a lower UTI, then nitrofurantoin will be preferable because of the lesser collateral damage as compared to the other drugs which may result in more damage to the gut flora as well. And again, host factors have to be considered, like younger patient or elderly patient who is more likely for toxicities like renal insufficiency, and whether the patient is pregnant. So beta-lactams are safer antibiotics which should be used. Again, nitrofurantoin should be avoided in patients who are have G6PD deficiency, in case of creatinine clearance less than 30, as well as in case of pregnancy. And TMP SMX should be avoided in the first and the last trimester. When we choose our antibiotics, it's important to choose the drugs which are achieving good concentration into the urine, and this table briefly summarizes the concentration of the various antibiotics. So here we have good concentration predominantly of the penicillin, the cephalosporins, which includes the cephalexin, then we have ceftazidime avibactam, and of course carbapenems. Quinolones have got excellent concentration. Here the levofloxacin has the best urinary excretion, which is 70%. Ciprofloxacin has predominantly 60% of the urinary concentration, and moxifloxacin has hepatic urinary excretion. So out of these, levofloxacin is the best choice if it is susceptible. All aminoglycosides have got good urinary concentration. Among the polymyxins, we have polymyxin B as well as polymyxin E, which is colistin. If a patient presents with sepsis, it's important to differentiate what is the cause, whether it's a UTI or a non-UTI related, because polymyxin B will not have urinary excretion and will not help, as this was also discussed by Dr. Kirtana in the first case. Then we have the drugs for gram positive. We have vancomycin, teicoplanin as well as fosfomycin, which may be used for the VRE. And of course, when we talk about fungal infections, the good penetration is that of the fluconazole, flucytosine, amphotericin B. The other drugs like the voriconazole, posaconazole or isavuconazole have very poor urinary concentration and should not be used. So, when we choose our empirical antibiotics, first is what is the likely organism, and then is the likely susceptibility it is going to have. So, when we look at the microbiology of the UTI, which is going to be discussed by Dr. Madhuri, 80% is caused by the Enterobacteriaceae, and then we have a few by the Pseudomonas aeruginosa, Proteus, as well as extremely low by the Acinetobacter baumannii. It could be also because of the Enterobacter cloacae, which is an Enterobacteriaceae. Similar data even from the West, which shows that the predominant cause for the UTI is Enterobacteriaceae, which is E. coli and Klebsiella pneumoniae. This is followed by the Proteus, Enterobacter. Then we have Pseudomonas aeruginosa. So, it's predominantly Enterobacteriaceae which are the likely organisms for the urinary tract infections. This is the ICMR data, which also suggests that it's Enterobacteriaceae for 70%. Then it is followed by maybe Enterococcus in close to 10%, and then the NFGNB, which is the Pseudomonas aeruginosa in a few of the patients. This is very important for us to know that it is Enterobacteriaceae which is going to be the most common. Then we look at the susceptibility. We all are aware that this is one of the, there has been evolution, but in we have very high prevalence of ESBLs in the hospitalized patients, 70 to 80%, and even in the community there is a high risk of 30% ESBLs. So, this table briefly summarizes the what should be started empirically in a patient who has got a lower UTI or a cystitis. So, the first would be nitrofurantoin, because of the various, it has a good concentration into the urine and again lesser collateral damage. Then we have TMP SMX, which can be used, which is for 3 days or so, and in case the patient is a men, then a longer duration of antibiotic therapy is recommended. The other options can also be amoxiclav. Fosfomycin is also recommended by a few guidelines. However, fosfomycin should not be used because as a monotherapy it can result in generation of resistance, plus it also results in diarrhea to the patient. So, if there are other options, that will be preferable. If a patient is having severe UTI, acute pyelonephritis, in that case IV antibiotics, and preferably if the patient is very severe, a carbapenem should be preferred, which is because of the Merino trial. In a less severe case, maybe a BL-BLI combination can also be used, and here the dose of piperacillin-tazobactam is to be considered. It should not be 12 hourly or 8 hourly. The dose has to be 4.5 grams IV 6 hourly dosing, and even the dose of cefoperazone sulbactam is 3 grams 12 hourly minimal, rather than giving a 1.5 gram 12 hourly dosing. Now, this is the ICMR 2019 guidelines, and that also mentions the empirical choice of drugs. Now, let us go to the definitive therapy here. So, we have this 52-year-old lady who has got diabetes, and then she presents with urgency and there is fever. She has leukocytosis and the urine routine is showing 50% cells. The creatinine has gone up to 1.2 and she has been empirically initiated on meropenem. This would happen in practically, that a patient who has developed pyelonephritis and is severe will be started on meropenem. Now, subsequently we have this urine culture which is positive, and this is the urine culture which is a midstream clean cat sample, as we can see here, with the following susceptibility. So, we have Enterobacteriaceae which is E. coli with a significant colony count, and as we can see here that the ceftriaxone is resistant, ciprofloxacin is resistant, ceftazidime is also resistant. We have susceptibility to amoxiclav, the BL-BLI combination of piperacillin-tazobactam, TMP SMX, of course URTA is susceptible, then we also have meropenem susceptible, there is fosfomycin which is susceptible, and colistin is intermediate. So, now what do we do with the antibiotics? Should we consider de-escalation once the patient has improved, or these are the options. Do we continue with meropenem as the patient is improving on meropenem? Should we switch to piperacillin-tazobactam with amikacin, switch to ertapenem, or switch to TMP SMX? Madhuri? Okay, so of course it's a very simple statement, and I think here this brings us to the discussion on the MIC and the susceptibility breakpoints. This I have mentioned a lot in my previous slides, and Prerna must, she knows it. So, what is MIC? MIC is basically the lowest concentration of the antibiotic which inhibits the growth of the organism. And this, what we see in the culture reports, that is the MIC which we get. Now, that has to be compared with its susceptibility breakpoint, which is not mentioned in the culture reports. So, what is this susceptibility breakpoint? This susceptibility breakpoint is obtained on the basis of various clinical trials. So, this is a chosen concentration of an antibiotic which defines whether the species of the bacteria is going to be susceptible or resistant to that antibiotic, and it is fixed. Whereas, the MIC which is seen or visible on the culture report is variable. It will depend from the species as well as from isolate to isolate. And it is important that the MIC which is available or visible on the culture report, that should be lesser than the susceptibility breakpoint. And we must know this. And for this actually our microbiology colleagues will tell us. But as physicians or infectious diseases specialists also we must know that there is a fixed susceptibility breakpoint for each of the, for a particular isolate, for E. coli, for a particular antibiotic here. And this in fact piperacillin-tazobactam, this is susceptible with MIC of 4, and initially this was 16, this has been revised by the recent CLSI guidelines, and Dr. Prerna helped me with this. So, this is 8 now. So, while most of the clinicians tend to compare that the TMP SMX is 20 and we have say colistin MIC as 0.25. So, this is going to be, this is likely to work better. It is not like this. it has to be compared horizontally with its susceptibility breakpoint. So, even if the TMP SMX is 20, the susceptibility breakpoint is 40 and it is much lower. Similarly, if we look at the ertapenem MIC, which is 0.5, the susceptibility breakpoint is 0.5, so it is going to work. So, basically for our ideally the crux is the susceptibility, the MIC of the organism should be much lower than the susceptibility breakpoint, and here we have to think about de-escalation as well if there is other susceptible antibiotics. So, instead of meropenem, once the patient improves, we can choose ertapenem as a alternative drug. Why? Because it has a good urinary concentration, it is not nephrotoxic, and it can be given as a single daily dosing and can also be given as a IV or a IM therapy, intramuscular dosing on a outpatient as an outpatient antibiotic therapy. Meropenem can be continued, however, it is going to be, it's a much more broader spectrum, it is 8-hourly, so it's better to de-escalate down. Now, in a patient who is in severe sepsis, should we start with ertapenem? No. If suppose the patient has severe sepsis and there is a chance of bacteremia, then ertapenem, being a drug which is highly protein bound, should not be used initially as an empirical therapy. It can always be a step down therapy. So, start with meropenem and then once the patient stabilizes, then ertapenem can be used. The other important alternative therapy can be this TMP SMX. Although the MIC is 20, but it is way below the susceptibility breakpoint of 40. It is a very effective drug both for the upper UTI as well as for the lower UTI, achieves good concentration into the kidneys, as well as is available both as IV and oral. So, we can switch the patient to oral therapy and the IV cannula can also be out. Coming to colistin and fosfomycin. Fosfomycin is a drug which achieves very good concentration into the urine, however, it is a very broad spectrum drug, and colistin, although the MIC is low, but is nephrotoxic, besides has 25% urinary concentration. So, this will also be not the choice as per the antimicrobial guidelines or the stewardship. So, now we have this another patient who has presented with UTI, and this is the imaging which we have here. What do you think it is? Cystitis, and can we see something else? Yeah, this is emphysematous cystitis, yes. So, in this patient, what do we do? BL-BLI combination, meropenem, fosfomycin or poly-B? Meropenem, yes, empirically of course meropenem, we all, I mean this is just, this was the susceptibility profile, this was E. coli, and this was an, as we can see here, this is an ESBL E. coli, and initially we started with meropenem and subsequently the patient was discharged on amoxiclav because this was susceptible. So, even de-escalation to a oral antibiotic after an initial IV therapy should definitely be considered, and this patient did well. For 5 days amoxiclav was given at a dose of 1 gram 3 times a day. It's important for us to remember that all these breakpoints, they are actually based on the serum concentration, and many a times the antibiotics which we choose, they achieve different concentration in the different site of infections, and sometimes the urine concentration of the drugs is going to be much higher than the serum concentration. So, the actual concentration which the antibiotic is achieving in the UTI is going to be much more, and sometimes even if there is a borderline MIC, the drugs will work with the appropriate doses or little higher doses of the antibiotics, especially during the, especially in case of cases of augmented renal clearance. So, that is why we also have this different BSAC breakpoints for the GNBs, though they have different susceptibility, urinary susceptibility breakpoints which is mentioned for the different drugs. Now, I will mention about this case. This is a patient who had this 56-year-old gentleman who had genitourinary candidiasis, and then subsequently this patient was an ampho B as well as 5FC. He had bilateral PCNL in situ, and this patient had initially a urine culture which was Klebsiella pneumoniae, which was a CRE, as we can see this here, and then subsequently when he developed fever with his creatinine jumping up to 1.8. Now with this urine culture, what can be done? Which test can be done? Okay, so we actually performed this expert carbar immediately on this, and this was oxo-48. So the antibiotics instead of the colistin and fosfomycin, and this was way back I think in 2021, he was initiated on ceftazidime avibactam and the patient improved. So these are the rapid tests, the molecular assays which can be done, and Dr. Neha is going to discuss more on the rapid assays and the POCT. This was the subsequently the E test which was performed, the Casavi was susceptible with MIC of 1, and this is a table which can help us in choosing our antibiotics based on the mechanism of resistance. As we can see here, if it is say oxo-48, then we can go for ceftazidime avibactam. If there is NDM, then it is a then it is aztreonam avibactam. If that was not available earlier, because it was not available, we were choosing the combination of ceftazidime avibactam with aztreonam for covering, or the NDM with oxo-48 co-producers. Now let's just quickly go through the third most important thing which comes to our mind is whether the UTI is complicated, what are the risk factors, and is there any role for surgery. So this is a patient who is a 16-year-old boy. He had severe flank pain, he developed leukocytosis, and this was a CT scan which was done, which shows there are multiple abscesses in the bilateral kidneys with a right perinephric collection. Initially the cultures were not sent, and he was initiated on meropenem, teicoplanin, ufloxacin and metrogyl, and the pain was persistent. Then he underwent a IR guided drainage, and from the pus the Staphylococcus aureus was obtained as the positive culture, which was a MRSA. This is oxacillin resistant. So that's when he was referred for the infectious diseases opinion. So what based on this culture report, we decided to treat this patient with teicoplanin instead of vancomycin, because that would be more nephrotoxic. So here we can see vancomycin susceptibility is 1. Although teicoplanin is here it's 0.5, and the patient improved. But as ID, it's important for us to even recognize that why has he got a MRSA? MRSA, so we inquired further, and this patient was giving history of skin abscesses in the past. Since the childhood, there was no other history of any immunodeficiency, and that's why this is a case of CA-MRSA with multiple renal abscesses and hematogenous abscesses in the kidneys. So what is important is even prevention, and that's why decolonization with mupirocin was offered to him, and he was cured. When we talk about abscesses, intrarenal abscesses more than 5 centimeters in size, they definitely require percutaneous or a open surgical drainage, and whenever there is an abscess, it has to be surgically controlled. Source control is very important for the cure of the infection. To summarize, it's important that we recognize the infectious diseases syndrome, the site of infection, and then possible pathogens, then obtain the appropriate cultures, perform the right diagnostics, which includes the radiology, and then consider the antibiotics, which is based on the local antibiogram, the patient specific factors, the PKPD as well as the cost, and once the culture results are available, then we revisit and de-escalate as well. So I think this will, I hope this was useful, and we will take away some key points which will help in the clinical practice. Thank you so much.
Any questions?
Yes, Dr. Anshul.
With Niftran and Alka-Citral together.
No, I didn't mention that it works. I said, yeah, so we need to look at the urinary pH. If the pH is acidic, we need to make it alkaline. If the pH is alkaline, we have to make it acidic.
So does Niftran work better with acidic pH? Is it like that? It was mentioned in one of your slides that for nitrofurantoin, acidic pH and vitamin C.
No, I didn't mention that.
Okay.
No.
Thank you for clearing.
Minimum inhibition concentration and the susceptibility thing. So I need to know ki as a lab what you want as a clinician to tell us in culture sensitivity reports that what do you want, which guidelines to follow. You want us to follow ICMR guidelines, CLSA guidelines for antibiotic sensitivity, or you would like to prefer higher tests, maybe in the future, near coming future, by LCMS, would you like to do any concentrations of drugs, antibiotics, the toxic drugs, maybe?
Okay, so as a clinician, first is whether it's a susceptibility and the MIC is very important. And then if suppose, what I would like is, if suppose there is a culture positive, then it should be informed to the clinician and also request for further diagnostics which can be done. For example, like we can do the lateral flow assays which are rapid test, also expert carbar which can be performed, and that will help the clinician in arriving that which antibiotic can be chosen. It is sometimes difficult for clinician to know that that this has grown until the information goes away, and by the time we reach out, then the sample is discarded. So it's better that there is a more interaction between the lab and this.
So as soon as the bacterial growth or whatever organism is grown, so we should ask the clinician which antibiotics would you like to prefer in the present scenario according to the patient.
See, usually in the, I think there is Vitic cards which are available for particular, and then if we want additional antibiotics, that we request our clinicians, right? So for example, it's basically the mechanism of, besides this, the mechanism of resistance is also important, and it can be early while the phenotypic DST arrives 24 hours later. So if there is a positive culture, a notification to the clinician, especially in labs like yours, which are like, which also deal with not just one institute, but with different clinicians who have their independent OPDs. So automatic reminder to them that there is a positive culture, and if suppose it's a GNB, then we can tell them that other tests which can help are the lateral flow assay or the expert carbar to know the mechanism of resistance can be done. The results will be available in just 1 or 2 like 2 hours or so, and whereas if we wait for the final result, that will be 24 hours later. So it's up to that clinician whether they want the test to be done immediately or not.
And any drug levels would you like to measure in toxic drugs for urine or serum?
So basically we
by LCMS I'm talking about.
Yes, of course. TDM is a very, very important concept, and we are doing vancomycin TDMs. There has been a concept for doing teicoplanin also, but it is not available. So if you can start, that will be great. Aminoglycosides is also. Few of the centers down south have been doing even drug levels for colistin.
So we want in serum first because that is better, because otherwise excretion can go into gut as well as the urine. So you would like to measure these serum levels.
Yes, absolutely. And drug levels even for the antifungals, which is not really commonly available even in Delhi NCR. So we can go for drug levels for voriconazole, POSA and isavuconazole.
Thank you for beautifully explaining, ma'am. Thank you.
Dr. Neha, how common do you see fungal upper pyelonephritis in your practice? I mean, patients who are predisposed, immunocompromised, diabetics, how common actually is it? Do you see it often, or it's?
No, I don't see it often. I've seen cases, and those cases become the typical infectious diseases cases.
We have seen histoplasmosis also, I think we are present.
Yeah, well, we always, you always read in literature that in diabetics, immunocompromised, fungal is a common etiology, but in practice, and even there are radiological clues, but in practice, you don't see it too often.
Absolutely. So, diabetics, candiduria is very common. but that is asymptomatic candidiuria even in a diabetic patient has not to be treated until the patient is neutropenic, undergoing urological intervention or pregnancy. So though candidiuria is common, but cystitis will be less common as compared to the Enterobacteriaceae. The fungal UTIs are definitely much less common, but they have to be considered. We should not miss them.
And once you are considering a fungal UTI, would you wait for the or would you start them on antifungals? Well, those are also toxic drugs. The patient doesn't grow anything on culture. I mean, what are the how would you approach that in terms of treatment?
So I would look at the patient first, that what is the severity of the illness the patient is presenting and which antibiotics the patient has received. So if the patient is very sick, has received broad spectrum antibiotics to which the patient is not responding, if there is a urine routine which is showing that there is BYC, then there is a possibility of genitourinary candidiasis in those patients. Then I would start empirically. But if the patient is stable, not having symptoms, then I would like to repeat the cultures again, do an imaging to check if there is actually cystitis or any other complication, and then give the definitive antifungal therapy.
Thank you.
Thank you, ma'am. A big round of applause for Dr. Neha.
Excellent talk, Dr. Neha. It was actually so exhaustive, mesmerizing, and even I learned so much from it. Thank you so much.